Hello, and welcome to a new edition of Education is Best Medicine, supported by Eyes of the Conscious Soul. Miss Howard is on vacation with family. I want her to have a great time, and be safe out there. Today's show is in our continuing series. I kind of Google searched the top 10 concerns. And we've talked about, physical activity, obesity, food sources, hypertension, diabetes, and what came up was substance use disorders and behavioral health issues. We talked a lot about depression and anxiety and PTSD, but the flavor of this is kind of staggering. And that's kind of what we're going to do. But I wanted to kind of talk about, again, I want to keep this piece going about women's hair care as we move toward the summer, and exercise is a really important part of our program for obesity and blood sugar control and blood pressure control and just staying healthy. And I want to thank Patina and the Anointed Hands shop for providing these tidbits for us. And it says to keep in mind for exercise, women's hair is summer and summer's beginning. So you can have many protective styles. Most women will cut heavy sweater, cling with sea breeze. Sea breeze is an astrident. Just be careful you're not allergic to it, but it's really one of these strident that kind of cleans the scalp. Watch if you're allergic to it, of course. Sulfate again. All these products you have to watch if you're allergic to it. Everybody can't do everything, so it's something you kind of watch. But again, the sea breeze, the oil, replacing the oil with the sulfur oil, right? Because African Americans tend to do better with sulfur products. And again, wearing the locks are great if you can. And braided wigs to cover your hair and your head. You can use lace wigs with a dry adhesive. Again, you have to check you're not allergic to it. Most people suggest a patch test, and so in which you sample to see if the product is allergic. It's a small patch of your skin. A lot is done, in terms of dermatology and stuff for skin testing, so not uncommon. And make sure you kind of do the care issues, taking care of the tips, and part of the discussion is, yes, it's another reason not to work out, but we want to make it something you can do as opposed to what you can't do. This is Parthena's Anointed Hands hair tip. I also want to thank, if you're in the Oakland area, there's a place that I kind of frequent sometimes when I'm heading home, 5-Star Barbecue, and the owners are Price R. Colleton. They're they're a father and son team, and they're out burning. Telephone number is 1-707-307-8905. Again, if you get a chance, check them out. It's right on 54th and Martin Luther King Way, and I think they're out about 4 days. From Tuesday to Saturday, rain or shine, like they're doing it now. So. Right near the gas station. So I wanted to continue, and again, I want to thank all the great nurses, Nurse Gloria, Nurse Roslyn, just great nurses. Thank you for your care. Thank you for your work and the things that you do. Very supportive of you as Black nurses and Black women in general. Thank you. So in this Big 10 list that I had, substance abuse was really huge. And I had to kind of look at not just whether it's opiate or whether it's alcohol. It could be food. It can be sex. It could be money. It could be power. All those things could constitute a substance use disorder. And so to kind of put this in context, I was watching a documentary on PBS, and it seems that the original onslaught of the drug trade, particularly as it relates to heroin, which is modern day opiate, which is modern day hydrocodone, oxycodone, fentanyl, was a business decision by the Sicilian and the Italian families, right? The Italian mafia families in Italy, and the Sicilian and the American mafia, to kind of coalesce and make drug trade, particularly the use of heroin, a big part of their market. They were quite successful, as we can see already. And they weren't biased in the communities they sold to, so we have what we have. Here's some interesting facts that I thought. We're only 4.5% of the world's population in the United States, but we consume 80% of the opiates. There's a parallel with guns too. So kind of like when you have this unremitting consumption of opiates and then you put a gun in somebody's hand, it could be quite lethal. There's been a large increase in illicit use of prescription for non-drug uses. So there has been a large abuse in prescription drugs and opiates for non-drug use. And we define opiates as, a heroin-based drug, opiate-based drug, the drug being morphine or heroin or hydrocodone or tonicoline. And there's some substantial regional differences in abuse patterns that exist in Europe, Africa, and Asia. Heroin is the most prevalent illegal consumed opiate in America, and the Ocean, Australia, and New Zealand. And it's illegally diverting prescriptions for misuse. Example, codeine. So you see these mass situations where these drugs are being trafficked big throughout. Won't be specific about culture, it's just the fact that it's a business. And if it's a business, people are going to do business. Some of the demographics of illicit opiate users, and we're going to do some definitions, but just kind of give you some of the graphics. So male to female ratio for heroin users in lifetime for oxycodone shows that the use is higher in men than women. However, over age 65, a portion of females admission reporting primary use of oxycodone was 3 times that of men. Men, opiate users, were more likely to have illicit drug abuse and were more likely to abuse other prescription drugs. And this is some up-to-date. It's the manual that I use for my research and kind of fortifying to stay in the evidence-based band. So, and also I used a net CME, this article on opiate in 2022. And so it kind of got some percentages I thought were really interesting. And so the percentage of non-medical use of pain relief is among the predominant racial groups: white 3.7, Hispanic 3.7, Native Hawaiian Pacific Islanders 2.1, American Asian and Native American 5.0, Black or African American 3.2, and Asian 1.6. And what it says to me is that although the perception is that people of color use more opiates illicitly, that's not the case. That's just not the case. One of the reasons for that is insurance. One of the reasons for that is friends with meds. One of the reasons for that is the ability over the last few years up until recently to be able to get a large amount of money for your prescription. So, and one of the concerns with opiates is particularly troubling because these drugs cause problems with the breathing or respiratory depression. So it depresses the respirations and can cause death at all ages. So essentially we're seeing more deaths in young children and elderly. And the adolescent population is our future abusers. So it's a global problem. It's a global societal problem. And one of the reasons I got involved in it because I was seeing too many young folk addicted and strung out and doing all manner of things to survive. And we'll talk a little bit about that. And within the discussion or the background or the information or the epidemiology of overdose. Overdose is a major cause of premature death among opiate users. Non-fatal overdoses, for instance, would take persons have a loss of consciousness and respiratory depression occur, but not fatal. In other words, they get Traxon, they're able to get a drug that reverses the effect of the opiate on their system. I think that's really, really key. And the reason why I want to talk about this is that substance use disorder is a multifactorial issue and concern. And so we have to quit looking at it as it's just those people or someone else. No, it's not that. Ask Winona Ryder if addiction isn't an issue in her family. Ask the president. So it's not uncommon. The opiate overdose rate among women has increased faster than in men. And one of the reasons of that is that because women usually have less weight, it takes them less, whatever the drug, alcohol, opiates, to have an effect from it or to be at risk for that effect. Hormones protect women from a lot of things, but as they age, they have less protection. And they're at more risk. And again, this is kind of a tsunami of cardiovascular risk factors. And one of the reasons that women are more likely is because of chronic pain and they're living longer. Risk factors for fatal heroin overdose include male gender, single status, unemployed, history of heroin dependence, no current treatment for heroin dependence, intravenous drug use, alcohol or benzodiazepines. And I think that's important because a lot of the use is combination drug use. A number of deaths that we're seeing with fentanyl have to do with the other drug on board, usually methamphetamine, usually cocaine or alcohol. What I'm going to point out to you that really is that these are kind of like the glamour drugs. The bigger drugs of abuse are alcohol and tobacco, because I asked the question. So I think that what's unexplained with this recent rash of overdoses is that they're usually older and experienced users. We thought that when people got older or used a long time, they would develop tolerance, and tolerance would protect them, which means that they have to have more of the drug to get the desired effect. They would develop tolerance, and that would not be an issue. But just like heart disease, it don't matter. You can be across the spectrum. If you add on genetic issues and abnormalities, you add on, cardiac issues, lung issues, you're easy to overdose, and not necessarily older. I'm thinking of young folk with asthma or congenital heart disease. And what was also interesting, and this is from the CMT article, is that they died with a low morphine concentration, which means it wasn't of a dose that should have been high enough to kill them, which brings into it other risk factors. And the fact that the body's chemistry can only manage so many things, and you put all these things on it, it literally just can't handle it. Goes into shock. So I think that, and again, the highest risk to overdose are those that use drugs non-medically. And we're starting to understand that. And that got me into a discussion. This is from September 15, 2022. And I want to say thank you to Believe Radio and Curtis, always on the fly, always here helping, always making it work for me, and work for the community. And I really am humbled and thankful and appreciative that people kind of bop through and want to hear and see my discussion from a different kind of viewpoint, because it's a different kind of viewpoint, you know. And I think, you know, we should have different viewpoints. So the Post did an article on 9/15/2022, page 5, opiate settlement, 13 states to share $30 billion plus in payouts. Some of America's largest pharmaceutical companies have said at least $30 billion to settle their role in the national opiate crisis. Under the watchful eye of Rob Botha, the Shackley family and the company they own, Purdue Pharma, agreed to pay $6 billion for their role in contributing to the opiate crisis. This requires that Shackley name to be moved from buildings and institutions in California. It also calls for recognizing Purdue Pharma for a new company, which has been named the Noah Company. Noah Ark, okay. Noah Pharmacy, which will produce opiate addiction and overdose reversal treatments. Now, I have nothing against opiates. Again, the larger picture of substance use disorders, opiates they suck all the oxygen in the room. But in reality, the common discussions, the first 5 addiction issues in America, we'll talk about that. In other words, there was money involved. So I asked GBT chat, I asked the 5 substances of abuse. The top 5 substances of abuse in the United States were alcohol. Despite its legality and widespread acceptance, alcohol abuse remains a significant issue in the United States, leading to numerous health and social problems. It's the trigger drug, as far as I'm concerned, in my career. 2 is tobacco and nicotine. Although smoking rates have declined in recent years, tobacco nicotine addiction remains a major concern due to its detrimental health effects. Man, alcohol, liver disease, heart disease, pancreatitis, fatty liver, change in cognitive function, the ability to think, to function. Why am I thinking so slow? Tobacco, same thing. There's no good thing about smoking. And anything you read about tobacco and its use, and when you get to an addiction level, the effects are all bad. Primary lung cancer, primary esophageal throat cancer, nicotine and alcohol go everywhere in the system. Again, I just thought that was interesting. 3rd is prescription painkiller, opiates, and spent some time on it, but the misuse of prescription painkillers, including opiates like oxycodone, hydrocodone, has contributed to widespread opiate epidemic, leading to addiction, overdose, and death. And I would add in that fentanyl. And I always forget whether it's 10 or 50 times stronger, but it's strong. It has a strong addiction potential. And we have to stop looking at substance use disorder as a personal affliction and something that's not only physical, chemical, mental, environment, again, multifactorial. And just for me, I asked GPT chat, I want to name several medical conditions. I asked it, said, what are the life-threatening medical conditions could be confused with acute opiate withdrawal? And we're talking about nausea, vomiting, yawning, goosebumps, changing their eye pupils, usually dilated, feverish chills, nausea, chest pain. And because I like to study these things, I want to kind of understand is that man, you can have a friend that's withdrawn and think they're just withdrawing, and they're not. They need to get to the hospital. So this is the top 5 that came up. This first is sepsis. What? Sepsis from infection, right? Can mimic withdrawal. And it's the body's response to an infection. IV intravenous drug use, IV contaminated drug product, i.e. sharing needles. And the symptoms such as fever, rapid heart rate, confusion, sweaty can resemble those of an opiate withdrawal. Another one is meningitis. It's inflammation of the meninges of the covering the brain. It surrounds the brain and the spinal cord. Symptoms may include fever, severe headache, stiff neck, confusion, sensitivity to light, which can be mistaken for opiate withdrawal symptoms. Encephalitis. Now, infection. Infection is key in this. Inflammation is key in this. Just like substance withdrawal. But substance withdrawal ends, these will continue. The person would get much more sicker. They wouldn't respond. Even if you gave them something to use, they would still continue to get sick. And encephalitis is inflammation of the brain, often caused by viral infections. Symptoms may include fever, headache, confusion, seizures, altered mental status can overlap opiate withdrawal symptoms. 4 is low sodium. And it's characterized by low sodium levels in the blood and can cause nausea, vomiting, hypovolemia, dehydration. You've been vomiting all day. You've been using this drug and you're vomiting all day and you're dehydrated. And people just say, well, you just need to eat something. But really, your level of sodium drops. So from all the vomiting, that you are in crisis. Of course, combination drug use, alcohol withdrawal. Alcohol withdrawal can produce similar symptoms to opiate withdrawal, including sweating, tremors, anxiety, agitation, nausea. It's important to differentiate between the two, especially in individuals with a history of substance abuse. Benzodiazepine withdrawal, another drug. Benzodiazepines are drugs that are used, they're sedative, they're used for anxiety, depression. Common ones are Xanax, Valium, and can cause symptoms like anxiety, tremors, sweating, agitation, and maybe mistaken for opiate. Benzodiazepines are one of the hardest drugs to withdraw from because of the interlocking in the system. Because of the interlocking on the transmitters, because of the entire body being, benefited from the sensory production. Serotonin syndrome, which is a condition that happens when people have a reaction to what's called SSRIs or antidepressant drugs. And of course, the issue is to withdraw the drug, but they have to get to the hospital. Serotonin syndrome is a particularly life-threatening condition caused by an excess of serotonin in the body. Thereby, SSRIs block serotonin cycle and it builds up and issue. Symptoms can include agitation, confusion, rapid heart rate, high blood pressure, dilated pupils, and muscle rigidity, which can resemble opiate withdrawal. Thyroid storm is a rare but severe complication of hyperthyroidism, and is characterized by a sudden change in thyroid levels, and usually TSH up, high disease. And is characterized by symptoms that can cause fear. Again, fever, rapid heartbeat, confusion. Again, all these could mimic opioid withdrawal. And it's crucial for healthcare professionals to consider these and other potential medical conditions when assessing patients presenting with acute withdrawal. Proper diagnosis and management are essential for ensuring appropriate treatment and preventing complications. Do no harm. Share decision making. Agreeing that a therapeutic alliance that says that person says, oh, well, look, I've been using this, this, and this. Man, all it can make you withdraw at some point in time when the drug level drops below, whether it be methamphetamine or alcohol or tobacco or whatever. And also add to this is that you have to think about cardiac conditions, GI conditions, cardiac conditions like heart attack, pericarditis, aortic syndrome, aortic dissection, GI conditions such as Crohn's disease and ulcerative colitis, pulmonary conditions such as pneumonia, pneumothorax, hemothorax, cancer. You have to think about these things. And drug number 4 was marijuana. And the attitudes of the law, the attitudes of the laws regarding marijuana have shifted, being one of the most commonly abused illicit drugs in the United States. Well, okay, we just had a 420, right? So yeah. Stimulants such as cocaine and methamphetamine. Stimulant abuse, including cocaine and methamphetamine, continue to be a significant problem due to their addictive nature and harmful effects on the other body. And combination drug use, they are finding that a number of the recent overdoses in the Bay Area have been with a combination of methamphetamine and fentanyl. Now, won't bore you, but there's a neurobiology to addiction, and basically it states that drug addiction represents a dramatic dysregulation of motor. This is by a paper by George F. Cobb and Norman D. Barkla. I'm going to go to the conclusion. Drug addiction represents a dramatic dysregulation of motivational circuits that are caused by a combination of exaggerated incident salience, habit formation, reward deficits, stress surface, and comprise executive functions in 3 stages. The reward effects of drugs of abuse development and incident salience and development of drug-seeking habits in the binge/intoxication state involve changes in dopamine and opiate peptides in the basal ganglia of the brain. This increases negative emotional states and dysphoria. So it's a cycle. It's a repeating cycle. In the minute the drug level drops, the person gets anxious. They're sweating. They're withdrawn. And there's an increase in emotional states and dysphoria and stress-like responses in the withdrawal, and negative stage involve decreases in the function of the dopamine component, which means that these receptors start going through all these transitions because a drug like an opiate is displacing them or causing metabolic havoc. That's why diabetes and hypertension make these things worse, because you're already in a state of neurobiological dysregulation. Although the early research I just brought this because I had to want folks to understand this. Although much of the early research with animal models focused on the acute reward effects of drugs and abuse, focus shifting to the study of chronic drug administration induced brain changes that decrease the threshold for relapse, which corresponds more closely to human imaging studies in individuals who have substance abuse disorder. A chemical change, a structural change in the brain from I can take it or leave it to I've got to have it. So as we talk about substance use disorder, we talk about the main drivers: opiate, alcohol, methamphetamine, tobacco. These can all be in one person. What would that do to you? What does that do to you? I've seen it just make people absolutely psychotic. Define drug addiction, and I like Dr. Kolb and his colleague. Drug addiction can be defined as a chronically relapsing disorder characterized by compulsion to seek and take drug, loss of control and limiting intake, and emergence of negative emotional state, dysphoria, anxiety, irritability. I can't, if I don't have it, I'm not going to release it. I can't do anything. Oh, you guys, you got to help me. Okay. When access to the drug is prevented. No, Mr. Smith. No, Mr. James. No, Mr. Wilson. No, Mrs. Wilson. I can't write the prescription for you anymore. You've had it for at least 7 days. I can no longer provide the drug. That's primary care. Addiction medicine is I need to help you get treated. Substance abuse disorder are complex, multi-stage diseases that are characterized by disturbance in 3 major neural circuits: the basal ganglia-driven binge intoxication stage, the extended amygdala-driven withdrawal negative effect stage, and the prefrontal cortex-driven preoccupation anticipation phase. 3 parts of your brain that are driven, that can be driven to the addiction model, given the right circumstances. And so we kind of have to understand this more than, social deviant or not a good person or it's their fault, they're the way they are. That's not a good discussion. It's worth noting that the prevalence of substance abuse can vary over time due to changes in societal attitudes, variability, and enforcement law, among other factors. Substance use disorders are highly prevalent, according to the United States National Survey. 14.5% of individuals aged 12 over have a diagnosable visible substance use disorder in the past year, including approximately 10.2% with alcohol use disorder. We're talking about young folk, right? Alcohol use disorder is 6.6% with an illicit drug use disorder. So alcohol, tobacco, alcohol, definitely alcohol, gateway drug. Illicit drug use and non-medical use of medications alone are in combination with alcohol associated with a substantial portion of emergency room departments in the United States. How do we take care of folks? How is the assessment completed? A thorough substance use assessment includes detailed inventory of type, amount, frequency, and consequences of the patient's substance use. Meaning what happened to them. If they used, did they go to jail? Did they get DUI? Did they lose their job? Did they lose their wife? What happened to them? And is it still happening? Are they still self-sabotaging? Their perception of the use, I don't use, nothing wrong. I can control this. And readiness for change, we talked about it. Pre-contemplation, contemplation, plan, action, maintenance. And we'll talk about this from an addiction nature, but really it relates to relapse as the final issue in terms of maintenance, as opposed to maintenance. Additionally, we review past medical history and psychiatric history and assess co-occurring psychiatric disorder, commonly depression, anxiety, schizophrenia, bipolar, mostly depression, bipolar, anxiety, commonly, but it can run the spectrum. ADHD. Determine the type of severity of the patient's substance use. Diagnose substance use disorder or the conditions is present. We didn't used to think about cold disorders, but now we do. We have to. Identify barriers and facilitate to reducing substance use. Inform the development of a plan for treatment. And with that being said, one of the other drugs that we have to deal with is excessive caffeine. Excessive caffeine intake can cause several adverse effects. And it contacted the Poison Control Center, and the use of caffeinated energy drugs, most common non-serious effects were palpitations, tremor, agitation, GI upset. Less common individuals demonstrated serious neurological cardiac symptoms, arrhythmia, ischemia. Gee, think about the person that's withdrawing from opiates that is addicted to coffee. That's a mess. And we talked about the pattern use infers it changes your normal life pattern, although in terms of caffeine. Abuse versus dependence. This dependence is generally described as patients who meet 3 or 4 of the following criteria. Tolerance means they use the drug, that use higher and higher amounts of the drug in order to get a response. Withdrawal, without the drug, they start having physical as well as psychological withdrawal. They can't live without it. They're sweating, they're nervous, no one understands them. Substances taken in larger quantity than intended. So this determines dependence. And this is what I look at when we determine whether a person needs to be in a substance, a MAT program, either for opioid use or alcohol or both. And substance taken in larger quantities than intended, persistent desire to cut down or control use, time is spent obtaining, using, or recovering from the substance, social occupation, recreational tasks that are sacrificed. I lost the day, Doc. Pearson, I lost the day. I was there and I was going, and all of a sudden this morning. Okay. So, heavy caffeine use is associated with increased with other addictive behaviors, including tobacco, alcohol abuse, as illustrated in some studies. And again, we don't think of caffeine as an addictive substance, but it is. The coffee and my dad, the coffee and the cigarette in the morning. I drink coffee. Yeah. But understand the effects of it. And the possible long-term effects of caffeinated beverages are dose dependent. Caffeine is associated with it is associated with decreased risk of Parkinson's, Alzheimer's disease, alcoholic cirrhosis, and gout. But caffeine and decaffeinated are also associated with a lower risk of type 2 diabetes. Hey, that's what they tell you. 4 to 5 cups won't hurt you. For alcohol use in America is defined by a standard of 12 grams of alcohol. And that's kind of like a shot glass, right? And males under 65 should have no more than 5 drinks in a day and no more than 14 drinks per week. Females and males age 65, no more over 65, no more than 4 drinks a day for 7 days a week. Now that's females and males over 65. And I got a little caveat to that. First line treatment for alcohol use disorder should be naltrexone, but you have to ensure that the person isn't on opiates, because naltrexone is used for folks that have had opiate overdose. And what it does is it's a opiate antagonist, and it displaces the opiate off the neurotransmitter site in the body and allows the person to become alert and not very happy. Now with the alcohol, similar thresholds have not been established for gender minority population. In other words, what I just wrote you is mostly for white folks. There's no agreed upon definition of unhealthy use of substance other than alcohol. And again, history of substance use disorder, at 8, and again, alcohol, AA, past participation in NA or AA or substance use disorder. Again, the history, route of administration, oral, and in terms of substances in general, whether it's smoking or nasal, subcutaneous, muscular, understand the risk, particularly route in terms of IV is, again, heart disease. History of overdose. This is the history we collect, and driven more largely by synthetic opiates and combination drug use, and risk of overdose. Mental health and co-occurring mental health disorders and substance use as well as are well documented. Individuals with substance use are particularly at risk for depression, bipolar, PTSD, eating disorders. I had sexual disorders too. STU is a risk in elevated personality disorders, especially borderline personality disorder. Somebody, they're not having mental challenges, but they do. They're a little bit eclectic, you might say that, but at more risk, antisocial behavior, more at risk. And more patients that are actually going through withdrawal may present with anxiety, agitation, sleep disturbance, behavioral change, especially in withdrawal. Again, it's opiates. And the substance may vary. Doses sometimes withdrawal, sometimes the substances and doses and timing will cause withdrawal just because of the amount that's there or not. Patients may present with psychosis resulting from, again, back to, you have to look for other things besides withdrawal. Resulting from ingestion of stimulants, alcohol, cocaine, all these can cause issues that mimic withdrawal. Hallucinogens, amphetamines always draw for alcohol. Barbiturates, again, combination drug use is really big. We try to do a comprehensive mental status exam to include general appearance, behavior, interactions, speech and voice, oriented times 3, stages, any overt psychosis or hallucinations, and the presence of psychiatric disorder or symptoms should alert you to a condition of a particular substance use disorder. So when people have mental health challenges, they may be having substance use disorder also. That is the issue in that evaluation. That's the issue in the evaluation. That's the issue in treatment. That's the issue in treatment models, because sometimes the substance abuse is hiding the mental health issue, and sometimes the mental health issue is hiding the substance abuse disorder. And but in most mental health exams, even folks with addiction, the mental health exams are normal. And again, the issues of substance use can be associated with compromising function. Virtually every system of the body and the medical condition can develop, and that's why you have to look for early causes. This is what we talked about, that. And the risk of the toxicity from substance, removing the administration, high-risk behaviors is what happens when people are using to either to fortify their habit or, to satisfy people that feed their habit. Sometimes the hygiene is poor, sometimes it isn't. It depends. Sometimes it's weight loss, injections at the site. You can see this, family members, your children, you check their arms out in a loving way, right? 3 signs of nasal congestion, dry atrophy in the nasal nares, perforation from substance stimulants, evidence of acute intoxication, slurred speech, unsteady gait, pinpoint pupils, bizarre behavior, changes in level of arousal, sedation, heart beating too fast, tachycardia, injected eyes injection, red eyes, right? Sweating, runny nose, in particular the opiates. We use a score called COWS, and it allows us to look at certain aspects to determine whether this person is in the throes of withdrawal or addiction. And at some point, we try to get them to come back in withdrawal so that we can provide medicine called buprenorphine. And again, this is a systems issue: cardiovascular problems such as hypertension and heart failure, GI, kidney problems, again, as I said, pancreas, cirrhosis. It may not just be addiction. It may not be just withdrawal. Anemia, and usually the anemia due to loss of blood or nutrition. Again, folks have B12 deficiency due to poor nutrition. Pregnancy complications and are different, but women that are using need to come and seek care so they can be treated so that they are not withdrawing multiple episodes of withdrawal expose the fetus to adverse outcomes and the mother to adverse outcome. In fact, this whole issue around women in pregnancy has to have a whole new view because too many women are dying in childbirth because of lack of understanding the dynamics in the pregnancy. So we test basic screens, addictive drugs. Biggest drugs that are tested for is amphetamine, cocaine, cannabis, opiates, and PCP. In this area, benzodiazepines also, as well as fentanyl. Unless it's an emergency situation, you have permission for conducting I conduct my screening, my patients, and we need to be sure that their rights are observed, and that we get consents for any type of laboratory or toxicology screening that might end up in their record somewhere, on their job's desk because someone didn't do what they were supposed to do. And HIPAA prevents that. None of this information can be released without the patient's request or permission. So, I think that some of the risk factors, which were kind of instruments for substance use disorder, is a romantic partner with a substance use disorder, two friends that have substance use disorder, living in a community characterized by poverty and high alcohol and drug availability. Some of the social roles compose the development of substance use disorder, disruptive family, social relationship, failed to fulfill responsibility at school, work, loss of job, poor grades in school. 3, legal involvement, arrest for disorderly driving under influence. These are all risk factors for substance use disorder. Theft, financial problem, violence, child abuse. They call it adverse child experiences. And we are finding that some of these addiction and mental health issues start in childhood, intergenerational trauma. Now we're having people push back, folks that say, get off the whiny train, and this can't be that bad. You can be resilient, and that's all well and good, but you need to acknowledge that first. Then we can have that discussion about my resiliency and about what I should be able to deal with. Some of the other risk factors were violent behavior, again, child abuse, neglect, risky sexual behavior, multiple partners, unprotected sexual intercourse, fair, cheating, to engage in activity, stop engaging in activity that once enjoyable, new, DSM-5 diagnostic criteria for substance use described as one often taking larger amounts of over a longer period of time than was intended to a persistent desire to cut down or stop, although they can't. A great deal of time is spent in the activity, either looking for the particular substance or procuring the substance, or resulting from the effects of the substance. So you only need 2 of these to have a substance use disorder. So this is about 10 of them, but all you need is 2. Important social, occupation, and recreational activities are given up, reduced, or because of use. And these are great, but if the person says I've been using and I'm withdrawn, and I do a urine test and they're positive and they want to get treated, then that's good enough for me. Recurrent use in situations where it's typically hazardous to continue use despite having persistent recurrent physical or psychological problems, tolerance. We already talked about tolerance, withdrawal, severity, alcohol, and again, alcohol is broken down into mild, moderate, severe. And there are a number of diagnostic tools to assess the either dependence or current use and status in that current use. There are a number of multi-dimensional scale assessment for alcohol, for substance use, for opiate use. It's COWS. And I think that we have to make sure that people are getting in for treatment. We are making it accessible for them. We are making it non-judgmental. We are doing shared decision making. We are allowing people to direct their lives. And I think one of the biggest things that concern me is that how closely a person's life was tied up in their treatment, and it shouldn't be. And so that's why I like Suboxone, because the reality is once a person's using this and they really commit to using it, then they carry on as usual. Again, people believe in shared decision making. Greater than 40% of the folks that have substance use disorder appreciate the ability to be involved in decision making around their care. And again, helping with dependence and versus non-physical dependence, determining the level of treatment, and then when to stop. And that's what they want to be able to do. And I think, again, the DSM-5 is the direction in terms of how we determine and convey to the person that has a substance use disorder. And it's around the amount of use, around long periods of use, around inability to stop, recurrent use, getting in trouble about that use, just the general things. Family issues, breakup of marriages, jobs because of that. And what I found is a lot of the folks said it's not really even a problem. Nothing happened. It was not anything they were doing. Wanted to talk a little bit about, in one of the treatment issues, that the main target for opioids are the immune receptor, and they are concentrated in the brain's receptors. That's why it's such an issue for pain perception, reward path, receipt, respiratory function, spinal cord, GI, peripheral, neurotransmitter all over the body. And imagine that if you need that drug to sit on that receptor so that you feel good. Opioid binding new receptors are distributing widely in the brain, in the thalamus, and in the prefrontal cortex. It continues to impair, if not address it, impair thinking, individual decisions about how important the drug is to them. Again, in the nucleus accumbens, the ventricular tegmental area in the brain associated with euphoria and experience. So understand that these discussions around these neurotransmitters and the neurobiology of the disease, such as that these drugs, either through their placement on the receptor or removal, cause either euphoria or withdrawal. And one of the things that people are looking into is the biology and reinforcement. And we're almost done here. My goodness, this is a great time. I want to thank you guys for showing up. I want to thank Believe Radio and Courage. I want to thank all you folks for being who you are and joining this ride with me. The biology of reinforcement and the motivation of behavior. So why do we do what we do? How do we think this? Why is this such an important? If you understand that, you can understand to intervene at certain points in time to help. So positive reinforcement cells in the brainstem increases dopamine in the nucleus accumbens, and again, liking and wanting three and seeking to do more. And dopamine is a neurotransmitter that is a chemical messenger in the brain that helps transmit signals between nerve cells, neurons. It plays a crucial role in cell functions to include movement, motivation, reward, reinforcement, and pleasure. Understand that is the chemical of our emotions. One of the chemicals, at least. And in terms of how it works, it occupies several areas in the brain, how we think, what we're thinking about, why we think it. The primary and the systemic nigra and the ventral tegmental area. Again, these areas are part of the basal ganglia and the midbrain, respectively. Once dopamine is synthesized, it is released from the presynaptic neuron to the synapses to what do? Several functions: movement, motivation, reward, reinforcement, and pleasure. People that are depressed, they say they think they have lack of appropriate dopamine and they're imbalanced. Negative reinforcement cells in the ommata and gata stimulate anxiety, fear, distress, and how to avoid these things. So you got this yin and yang in your brain. One saying and dopamine, hey, it's great, we're gonna get all this stuff done. One, the area of your brain, obligata, is that you're anxious, you fear, you're distressed, you don't have enough drugs, you need more. The oblongata is a small almond-shaped structure located deep within the temporal lobe of the brain. Its primary function is the processing and regulation of emotions, particularly those related to survival instincts such as fear and aggression. You know how when people are withdrawn or they're having issues, they're always aggressive, they're always angry. The oblongata plays a crucial role in the brain's fear response, helping to identify potential threats in the environment and initiate appropriate physiological and behavioral responses. Additionally, it's involved in the formation and storage of emotional memories and how we perceive and react to similar situations in the future. That loop, the loop. Dysfunction of the oblongata has been implicated in various psychiatric disorders, including anxiety, post-traumatic stress disorder, and phobias. The nucleus accumbens. Nucleus accumbens is a part of the brain's reward circuitry and is located within the ventral striatum. Its main function is to process, to integrate rewarding and pleasurable stimuli, including those related to food, sex, social interactions. And so if you don't know what to do, blame your nucleus accumbens. And social and addictive substances. We experience something pleasurable and eating a delicious food or engaging in enjoyable activity. The nucleus accumbens is activated and releases dopamine. There it goes, that pleasure neurotransmitter is social reward and enforcement. Dysfunction of nucleus accumbens and the broader reward system is a part has been implicated in addiction, depression, and so neurotransmitter, neuroplasticity, structural changes in the brain. Both the oblongata and the nucleus accumbens are interconnected with the brain regions and work together with other structures to regulate emotional responses, motivation, behavior. Their intersections contribute to our ability to navigate the world. So that's why brain trauma is such an issue, because it messes that chemistry up. That's why drug abuse is such an issue. It messes that brain chemistry and structure up. And sometimes you're left with nothing. I want to thank you folks for showing out and showing up. It's been an interesting year. It continues to be so. I am blessed. I'm blessed to have family and friends. I'm blessed to have my son home. I'm blessed. It's absolutely blessed. My grandchild just sent me a picture. Cute. So we're going to keep it moving here. The thing about substance use disorders, some great treatments. We won't have talk about those, but man, you know, if you are having problems, get to one of the treatment centers. Call them up. They're MAT treatments all over the Bay Area, and they're waiting to take your call and get you in there. Because the treatments are much safer. Buprenorphine, which is a partial agonist antagonist on the mu receptor, as well as the kappa receptor, which takes away the craving, as well as displacing the opiate drug. Again, in combination with naltrexone, this Suboxone works to again displace the opiate off of the system and place the buprenorphine on, and thereby stopping the cravings and all those kinds of things that limit people's functioning and make them feel addicted. Last thing is the rating system, and it's resting pulse, sweating, restlessness, GI upset, pupil size dilated, withdrawal, bone aches, yawning, irritability, goose flesh, runny nose, teary eyes, and fentanyl is particularly special because you, instead of being able to wait a shorter period before you can come in for induction, you have to wait a longer period if your drug of choice is fentanyl. It's done progressively. I've done it for patients, and they've done real well. And so I think it's something, if you are having an opiate issue, alcohol issue, you need to get into treatment and to get yourself taken care of. It's been so nice. I want to thank you for doing what you do, and we will see you next time.